panel is on GI clinical care. And I think you guys might be able to ask some of your more practical questions to our speakers, Dr. Lee Bass, Associate Professor of Pediatrics, Director of Endoscopy and Clinical Practice, Director Division of GI, Hepatology and Nutrition at Ann and Robert H. Lurie Children's Hospital of Chicago, Northwestern University Feinberg School of Medicine. That was a long one.
All right, thank you. My name is Lee Bass, and I'm a practicing pediatric gastroenterologist outside of, or in Chicago. I'm at Northwestern University and at the Ann and Robert H. Lurie Children's Hospital of Chicago. And, you know, my interest in terms of taking care of kids with not only several children that I have in my practice with 15q duplication syndrome, but all types of kind of more rare genetic disorders, which are fairly poorly understood in terms of the physiology, is to really help these children do well from a gastrointestinal standpoint. So what I'd like to do today is just kind of really go through some principles of how I think about GI care in children with neurologic disorders, children with these types of genetic disorders, and with the hope of really entertaining quite a few questions from you to talk about kind of some of the principles of how I think about things. Because I think that is kind of the most important thing, that we want to make sure we have a common language about how we think about things. And for you as the parent who knows your child and this condition, no matter how much I study it, much better than I will, can think about how clinicians think about these types of things, and that can help you maybe find solutions for any of the issues that you may face. So we're going to talk about some of the principles of GI care, and I didn't prepare too many slides. I didn't want it to be too busy. I really wanted it to be more of a free-flowing conversation for you. Well, let's start talking about, you know, from head to toe, thinking about things like gastroesophageal reflux disease. So gastroesophageal reflux disease is a condition where you have increased amounts of acid moving from your stomach up into your esophagus, and sometimes up even further into your larynx, your voice box, and potentially aspirating down into your lungs. And gastroesophageal reflux disease is different than gastroesophageal reflux. We talk about babies and we say that all babies have gastroesophageal reflux, many of whom will spit up quite frequently, but few of them actually have gastroesophageal reflux disease. In terms of gastroesophageal reflux disease, this acid, this gastric contents that are coming up seem to be disturbing the esophagus, causing inflammation in the esophagus, causing children to not want to eat, causing children to have spit ups or vomiting, causing children to potentially have coughing or respiratory symptoms following an ingestion of their meals. Gastroesophageal reflux ends up being very common in children who have all sorts of neurologic disorders as a result of the many of the different, sorry about that, about many of the different things that may potentially cause them to increase their intra-abdominal pressure, increase the amount of substances that are coming up. This can include being wheelchair bound and having kind of poor posture, or spending much of your time sitting or in a reclining position, or potentially with increased seizure activity. These things can happen. At times, gastroesophageal reflux may be clinically silent and you may not know that you have it. At times, gastroesophageal reflux may be very clinically significant and can range from symptoms of irritation, symptoms of feeding refusal, symptoms of vomiting, symptoms of spitting up, and symptoms kind of abdominal pain and irritation. The tests for gastroesophageal reflux are fairly straightforward. It tends to be a very clinical diagnosis, and a lot of this is in the history. And a very good clinician should really ask you a lot of questions about kind of what is going on, what are the symptoms, and when is it happening. We can do several different types of tests for this. One is just simply a trial of medication. Most of the medications that we use, including H2 blockers such as famotidine, or PPIs such as lansoprazole or omeprazole, are fairly benign and relatively easily tolerated and easily given. And so sometimes, particularly if patients are nonverbal or have difficulty communicating, we will give a short course of those medications in order to see if it makes a difference. And then if it makes a difference, that kind of proves that that was the problem. Other testing is a little bit more invasive. And these can include endoscopic evaluation with a scope, or potentially doing things like pH probes, where we actually measure the amount of acid coming up into the esophagus and try to correlate that with symptoms. And certainly those are a little bit more invasive, and really I kind of save these for children with significant diagnostic dilemmas, children where we're considering more drastic treatment of the gastroesophageal reflux disease. There's certainly, in addition to medical therapy for gastroesophageal reflux disease, there can be some surgical treatments for gastroesophageal reflux. The main one is something called a Nissen fundoplication, where basically you create a one-way valve at the top of the stomach, so that prevents the gastric contents from coming up into the esophagus. And that can certainly work, although that is not certainly an option that I would recommend for everyone. I tend to save that for children who have respiratory symptoms and significant respiratory concerns related to gastroesophageal reflux disease. Long-term and long-standing gastroesophageal reflux disease, which may be particularly in older children with these conditions, can include the development of a precancerous lesion called Barrett's esophagus. And this is something that if we find it, we need to monitor it and follow it, because it can turn, it has the potential to become pre-malignant over the course of many years. And as children are able to kind of live and be supported as longer, we will start to see more of this, because it simply does happen in children with longstanding reflux. I want to talk a little bit about feeding, nutrition, and growth, and I'm going to combine that with use of G-tubes and J-tubes. So feeding, obviously, what we all want is for our children to be able to feed by mouth and for their nutrition to be optimized based on that. The realities of life, and certainly for individual children that works out well, and for other individual children, it doesn't. And these children have a really hard time eating, a really hard time maintaining their nutrition, a really hard time maintaining their weight simply by oral feeding, whether it's because it's not safe for them to feed orally, or whether it's because they simply don't have the desire, or they have an aversion, maybe due to gastroesophageal reflux disease, or because simply their neurologic status just prevents them from being able to eat well or eat efficiently. I tend to use G-tubes or J-tubes, where we put a tube directly into the jejunum or into the small intestine as a tool. I certainly don't recommend it for everybody. But oftentimes, the circumstance that I start to use these tubes include circumstances where the act of feeding has prevented either the family from having a quality of life, has prevented the child from having a quality of life, or simply their nutrition cannot be maintained. And the goal of the tubes is to use it as a tool to separate feeding from the ability to, or to separate feeding by mouth from your nutrition. You can provide nutrition, and then you can separate that from feeding by mouth. And in general, in my experience, when I've gone to use tubes for the children who I really do think deserve it or need it, it generally is a very big relief of anxiety within the household, because they now know, the parents now know that they have a route to give their child nutrition without having to suffer the anxiety of the child not eating, not wanting to eat, or simply having such a terrible aversion, or it not being safe for them. So the next thing I want to talk about is constipation. And clearly from the study in that was done in 2015, it shows that many children with 15q duplication have constipation as well as gastroesophageal reflux disease. So I think of constipation as defined kind of by this criteria that we use as GI doctors, something called the Rome criteria, which is either painful defecation, a lack of ability to defecate, or abdominal pain that is caused by an inability to defecate or really hard, very voluminous stools. Oftentimes, the medications that children can be on can certainly contribute to the presence of constipation. So treatment of constipation is in a number of different ways. It includes stool softeners, and there's a number of different stool softeners that we may use. One of the stool softeners we use, which has been a controversial thing within within a lot of different communities, is Miralax, and I'm going to address that. So Miralax, to think of it, is it's a water magnet. So actually, I'm going to step back a second, and I apologize that I'm kind of jumping all over the place. In terms of constipation, constipation occurs because the stool or the poop spends too much time in the colon. And as a result, the colon just absorbs all the water in the poop, and the poop is thus very, very hard and hard to get out. And then when the colon is trying to squeeze against a hard poop, that's what kind of creates the symptoms of pain and cramping. So what Miralax does is it acts as a water magnet. It brings water, it's not absorbed, and thus it brings water into the colon and allows for there to be a liquefaction of the stool that's there. It works very well for that purpose. Certainly there's been controversy lately for children who have potentially some behavioral side effects that are brought about by being on Miralax. The thought is that the Miralax itself sometimes can cause cramping. And certainly in certain children where one of the few things that they can control is maybe a withholding behavior of them not being able to poop, having that poop kind of start to come out of them and feel can be very uncomfortable and can release all sorts of other aggressive behaviors. So that's kind of what we think was going on with Miralax lately. That being said, in the right child, Miralax works great. And Miralax is a very useful thing. The right dose of Miralax for a patient is the right dose of Miralax for that patient. I have 16-year-olds who are on a quarter capful of Miralax a day. I have 2-year-olds who are on 2 full capfuls of Miralax a day. It's whatever will work to have a soft, relatively easy to pass bowel movement. There are lots of other medications, though, in terms of stool softeners. One is a medication called lactulose. Lactulose is a sweet, syrupy, non-absorbable sugar that does a similar function. It creates water coming into the stool, into the bowel, and that can allow for there to be a softening of the stool. The next thing is milk of magnesia, which also works to soften the stool. And there are other natural over-the-counter products out there. There's something called Natural Calm, which is magnesium citrate. You can also use things such as prunes. There's such a thing called Smooth Move tea that also works well. Another class of medications that we use for constipation are stimulants. And the goal of the stimulants is that you take the stimulant and it makes your colon contract and makes your child have a bowel movement. And so medicines in that classification include things like Senna, X-Lax, or Dulcolax. And what these medicines are they help the child go to the bathroom. Sometimes that can cause cramping. However, if you have a child who really won't go to the bathroom for a long period of time and they're having symptoms of that, that can allow them to evacuate their bowels, and it can allow them to not have kind of the over filling of the bowels that we would otherwise see. There are newer classes of medicines that have come out for adults with irritable bowel syndrome with constipation. You may have seen these advertised on TV. These include medications such as Linzess, Zelnorm, Amitiza. There's lots of these. And a lot of these work by kind of both enhancing the efficiency with which the colon works and also creating, having the body make an osmotic effect to create liquefaction of the stool itself. They work very well. They have to be used very carefully, particularly in children less than 18, because we don't really understand how they work well in those groups. But those may be options for your children, particularly if Miralax is not working for you or some of the stimulants are not an option. So the last thing with constipation is that nowadays there are more and more options for other types of therapies, including some potential surgical therapies that can work for children. One is surgical procedures that can cause what we call antegrade enemas, where we put almost like a G-tube based device in the right side of the intestine, right side of the large intestine. And then through that device, you can inject saline, which can allow the child to kind of let loose a bowel movement once a day. And you do that every day, every other day, every 3 days. And that can keep that child in really kind of good behavioral aspects from the standpoint of constipation. Certainly also there can be enema therapy that will work for the right child. And we can talk about that. So really what I wanted to do was just give you an overview of GI manifestations in this. And I would really love to entertain some questions and try to have some, maybe people can learn from asking the questions. I'll try to give you very practical, kind of some of the practical advice for how I deal with these. So thank you very much for allowing me.
Thank you so much, Dr. Bass. So we have a lot of questions. For a nonverbal 5-year-old that seems to have some type of GI issue, how would I determine if it's more a reflux issue or a constipation issue? He is on guanfacine and oh my God, I'm so bad at this, clonidine, which could be contributing to constipation. So how much should he ideally be pooping?
Sure. So my goal is for children to have a soft, relatively easy to pass bowel movement every day to every other day. Now, sometimes your mileage may vary a little bit from that standpoint. We certainly will have children who are pooping every 3 days and they're kind of otherwise fine and everybody's happy with that, that's how they're stooling. Really, we want them to be able to have a bowel movement and not have any other symptoms. So if you see that your child is extremely anxious or irritable or in pain prior to having a bowel movement, and their bowel movements are relatively infrequent, then that may be your child may benefit from either a stool softener or a stimulant to have your child go more frequently. I will sometimes use the combination of both Miralax and a stimulant such as like X-Lax or Senna in order to kind of balance this, where I keep the stools soft enough so that the child can pass them easily without pain. But then if they haven't had a bowel movement in more than 1 day, I will then have them take 1 dose of Senna and that will evacuate their bowels. Again, that will then be easy to pass. And then that should allow for that child to have an empty colon. I always like to say a happy colon is an empty colon. And that can allow for your child to hopefully have less symptoms or less irritability secondary to the constipation. Now, if that's not the case, if you're not noticing a change or you don't notice a difference, if you were to try a strategy like that, then a strategy to assess for reflux, it really might be a trial of medication. And certainly you can be invasive and do a scope, but really, I want to be practical. I don't want to put kids through testing that they don't need. So a trial of something like famotidine or a trial like of a medication like lansoprazole, certainly, and observing to see if you see an improvement in your child's symptoms may be a very reasonable thing to assess for this. It's certainly worthwhile, by the way, as an aside, that we do certainly see, and it really wasn't studied, at least in the papers on 15q duplication, but certainly we do see children that have milk allergies or other types of food allergies. And so in certain kids, if you're really kind of struggling and you think that there might be issues within their their stomach, a trial of elimination diet, first trying potentially dairy, trying maybe an egg elimination, maybe a soy elimination. Some of those things may be reasonable to try and get their symptoms improved. I really try to be pragmatic about that. I don't want to eliminate just everything, but that is also another thing that we can sometimes try. So I hope that answers your question.
Great. I'm kind of jumping around a little bit just to see, because some of them are going to take a little bit of time. So what we'll do is we'll send all of these questions to Dr. Bass.
Yeah, I certainly will be happy to answer as much as I can.
That's great. Thank you. I'll do one more, and I'm just honestly arbitrarily choosing. Let's see. We're nervous about long-term use of stool softeners, such as body developing reliance on it and side effects. Are these concerns warranted?
So the answer is yes, children can become dependent on these medications. Are the concerns warranted? I think that really depends on having a conversation with your provider. So here's the way I generally deal with this. So when you are taking Miralax, your body gets used to the fact that it can't absorb that water from the colon because that Miralax is in there and that's soaking up all that water. And as a result, the large intestine or the colon makes a lot more water transporters that it puts in the wall. So if you were to go cold turkey on Miralax, you would have some really, really hard poops very, very fast. Now, that would go away after a period of time as your body would re-equilibrate, but certainly that type of dependence can occur. Certainly patients who are on long-term stimulants, they also may potentially require these stimulants after a period of time to be able to have a bowel movement. And so all these children who are on these medicines, they need to be tapered off them very carefully when they are able to be tapered off. Now, all that being said, I think you need to look at the risk benefit, looking at the benefit to the quality of life for your child in terms of being able to have these bowel movements, in terms of being able to not have the side effects of symptoms of constipation, and make that determination as to what is best for your child. I certainly try not to keep every child on Miralax, and I come up with a weaning process to try and switch to fiber-containing formulas or put extra fiber in the diet, and then try to wean off the Miralax very, very slowly so we don't go cold turkey. But that doesn't work for everybody, and certainly for some children, particularly if they need to be on long-term anti-epileptic drugs, and they really need to be on these medicines that cause the constipation. Sometimes we have to battle that, and we need to kind of take. We need to see that there's some benefit from them being on those medicines. So we need to give the medicines to treat the symptoms that can be caused by this other medicine that causes such benefit. So
would you have similar advice about the risk benefit of suppositories?
Yeah, so suppositories are much easier tolerated and certainly can be used on an as-needed basis, much easier, and they don't cause dependence as much. Really, where I see issues with suppositories are children who simply cannot have a bowel movement other than with a suppository. So they just don't know how to push out unless there's a stimulation from the bottom. And in that situation, sometimes there are other things that we can consider doing, such as biofeedback. Sometimes, again, the use of stimulants may be beneficial. I have several of my motility partners who really deal in depth with children with severe motility problems, who really do use enema therapy quite a bit. And it really, again, changes the quality of life. It's messy, it's difficult for the 10 minutes that you're doing the enema, and then the rest of the time, your life is fine. So really it's kind of a conversation with the provider, but there's lots of different strategies to consider. And it's important, I think, that the families know that these strategies are all out there.
Wonderful. Thank you so much. And we will get back to all of you with your questions. And sorry that it's amazing to have so much engagement. I actually wish we would have more conversation.
Sure.
Yeah, thank you again. Next we have